You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Dr. David K Butler, Chief Medical Information Officer at KeyCare and the founder of Calyx Partners Consulting. We talk about Dr. Butler's background and his experiences undergoing digital health record transformations. We also discuss the gamification of the EHR user experience, the keys to designing software specifically for remote caregiving, and what it means to be a virtualist. Let's plug in. Welcome, David Butler, to the show. How are you today, sir?
Doing well. Thanks for having me, Craig. Yeah, I'm looking forward to it.
It's a pleasure to have you. We have known each other for how long?
Oh, man. Oof. At least, 15 to 20 years?
It's been almost 20 years. I just did the calculation in my head. It's been almost 20 years. I think it was 2005, so maybe 19 years. And in that time, you have been involved very significantly in the healthcare IT world. From all different sides. Where do we find you today? What are you working on today?
Oh, today, yeah. So I'm currently a couple of things going on with me. I'm an interim CMIO at a virtual company called KeyCare. I may have heard of them. Lyle Berkowitz, CEO there. Also the first Epic virtual platform ever in the U.S. So that has a lot of implications for connectivity. I think we can talk about that. So it's pretty cool. Doing some also CMIO type coaching, mentoring, advising some startups, third parties, things like that. Really cool stuff. Just a diverse cadre of things right now. So it's kind of cool learning new stuff, especially in the VC space. I just don't know that world at all. So a lot of cool stuff there.
Awesome. Well, why don't you give us a little background about how you got to where you are? You are a physician, I know that. Talk to me about what your specialty is, and how you got into this. How you got into this field? How'd you get to the current Dr. Butler we all know and love?
Well, first of all, I'm a Texan by a voice. Probably you'll pick that up sooner or later. The y'all will start coming out. Born and raised Texas, small town. When you think of Friday Night Lights, whatever you think of, that was my life. Went to Texas A&M undergrad. Then from there, med school in Houston, UT Med School. Now it's called McGovern. From there, across the street to Baylor College of Medicine. Trained in internal medicine and pediatrics. Yeah, did both of those. So they took 6 years and crunched it down to 4 and made me take both board exams, the peds and the internal medicine exams. So had I known that last statement probably would have changed a little bit. But did that. So it was really exciting. I learned everything 0 to 99, which is really cool. I love learning, right? And Baylor was just awesome just to learn in the medical center in Houston, right? During that time also, I had a daughter. And, this was I had my kid 1 month before med school and got married the weekend before med school. You do the math on that. So it was a little bit trickier. But through all that, in 2003, finished up residency, moved to middle of Pennsylvania with the kids and wife to a company called Geisinger Health Systems. And that's where I ran into a little clunky piece of software that was really slowing me down called Epic.
That Epic, first of all, I think the question that a lot of our audience wants to know is which is better, internal medicine or pediatrics? And why is it pediatrics?
Oh, pediatrics. You know what? That's a good question because folks say, why'd you go into med peds? Why didn't you just do family practice? Or why didn't you just do internal med? One or the other, right? And I have to think back. I was just talking to someone on the plane about it. I think it was a resident. She's a resident now, family practice last night. Crazy. And we were talking, and I think what it was that it was the residents that you work with as a third and fourth year. That after a while, you're like, man, they're really cool. They're like a vibe, and certain things like, what do you do? So I'm med peds. Like, what is this med peds stuff, right? So it was more of that. And I think it was, I guess his ability to medical code switch, like from pediatrics to adults. Like every 3 months you go hard internal medicine, especially at Baylor. It was very no jokes, button up your white coat, one of those, right? And then the pediatric side where you had to lose all that seriousness because you're dealing with parents, the kids and all that, you had to flip. So I think maybe that's what it was that attracted me to them, personality or something. But yeah, good feel, and I loved it. And that's a Geisinger was when I first started practicing and get my chops, because I was basically hospital-based. So when I got to Geisinger, they were looking for somebody that could go between hospital and clinic. And this is 2003. I'm like, oh, I like to do that because I don't really care about outpatient as much as I care about inpatient, because I know inpatient very well. And so joined Geisinger. and did a combo role where I was hospitalist in the morning, working at Mount Nittany Medical Center, a little local hospital there for patient patients. They use Meditech, by the way. And I think that's part of my origin story we'll get to. And then you go back in clinic in the afternoon, you see patients that were discharged a week ago from Miss Meditech, but they're in our Epic system and no information. So, and that was around 03 to 07. So that was around, that'll give you a little bit of insight on where we were in the world as far as paper, EHRs and all that.
So, but when you were a resident, you were at the VA, right? Where they went from paper to EHR in front of you. Did that happen?
Yes. Yeah. No. And that was probably some of the more traumatic events of my digital technology life. As a resident in the Houston VA, which is the largest federal building outside of the World Trade Center, right? In the U.S., the Houston VA is huge, right? We could literally run down a hall for it's got to be a quarter mile a hallway. It's crazy. And so, long story short, they flipped the VA from, we used to do these VT100 terminals where you write your note in the day. You write your note and type it in the computer, but then you do all orders on paper. You give it to the clerk. They fold it up, send it to the pharmacist, the nurse, whatever. The clerk was like the quarterback, right? And overnight, Craig, I joke with you not, the word, beep that. Can you beep that? Sound like I cursed, but I didn't. Okay, anyway. So yeah, overnight, I felt like the electronic record came in, and what used to take literally 5 seconds to start a drip, an IV drip, or whether it's nitroglycerin, nitroprusside, or whatever those crazy stuff we used to do, that would take literally 5 seconds, and the patient would have it in their veins in a matter of probably a minute. And all of a sudden, that process took 20 clicks, and I still wasn't sure if it went anywhere. And that was my first aha moment, okay, this thing can go off the rails if not done the right way. And so the VA was my starting where I first, as a resident, you had to use it if you're trying to get home, right? And so all these attendings, all the older docs were just circling, waiting on us to finish our notes so they could then copy and paste and get out of there. And that was the world. That was the world I got introduced to when it came to converting electronic health records to going from pixels to paper, as I call it. Crazy.
Well, it's funny. One of the things we talk about in human-centered design is transparency and visibility. And what you're describing is classic of going from a transparent system to one that was more opaque with the electronic health record. Because, as you said, when you wrote an order, you took the order and you put it in an area where a clerk or a nurse or someone was going to see it, or you gave it to them directly.
Absolutely.
And then you lost that ability because you pressed a button, and did it go anywhere? I'm not sure. Is someone going to see it? Did I do it right? There's no transparency there, and so you're kind of going against the laws of design at that point.
Yeah, laws of design, and more importantly, laws of human patient care was what was freaking me out. Right? It's wait, where did that go? Where is it? I think I ordered it, and that was when I realized we really got to get good real quick, real fast in healthcare as getting into this digital space, especially if patient safety was a driver of the EHR. And this is where I feel as I reflect back, this is my wish, I wish we'd have separated things out. I wish we'd have done documentation first, let that go first, everyone across the world, right? And then we bring in ordering, right? Inpatient or outpatient, but not only medications, right? So medications are the things that kill people, right? And so why do they make us order x-rays, diets? Oh my God, we were having to order every goddamn thing. I'm wait, something just jumped the shark here. And I think that's when I realized it in residency. And I was committed to say, hey, what I'm not going to do is give my career over to the technologist, okay? Because this wasn't a good vibe in the early 2000s with anybody in IT, okay? And I think any doc on the call will probably vouch for that statement, because we were in a new world and we felt like the hospital's IT could not meet us where we were as far as getting patients taken care of safely, effectively, efficiently, and all the quadruple aim stuff today. And so, yeah, I think our generation, I'll say our generation, 50, I'm 52, you're probably 90, I don't know, Craig. But our generation went from, I think we were the paper to pixels generation. We saw that transition, right? And now we're in this. And so those folks coming behind us have been benefited from some of the, they started their career CPOE. They have no paper concept, so I think that's easier mentally, but it's still kludgy. The workflows are kludgy still, and we got to keep working through those. And that's kind of what led me to what I do today is just kludgy workflows. I had to ask myself, who created this button? Find the person who made this button, because this thing is not working, right? And they always say, oh, it's working as designed. And I was like, but is it working as I would expect it? So how about that? Can we ask that question? Is it working as expected? Because I don't care how it's designed, right? I do care how it's designed, but it has to be designed and working as expected. Is that a safe statement?
I think it's safe. So how did you go from just someone, a physician using this technology, to someone trying to change it or at least understand it better?
I think, you know what? I think my aha moment came also the second revelation, one, pain in residency, two, when I got to finally at Geisinger working and using Epic, the software at the time, and in Mount Nittany's Medical Center, they had Meditech, and both systems were very difficult to navigate effectively. And it wasn't until my in-laws bought my son an Xbox, and he was too young for Xbox, so I took the Xbox and replaced with a Wii, right? Or whatever that was he needed back then, right? Or they wanted, not needed, didn't need any of it. But and it was when I opened up Xbox, I put in this DVD called Halo, came with it. I never heard of Halo, never really heard of Xbox at the time because I hadn't gamed since college. Man, I put this in, man. I remember the night I was in the basement. I put it in, I had a big screen TV because I treated myself from, going to get out of residence. Big screen TV, I'll do that. And then when I put it on this big screen TV in the basement, dude, that was a visual experience, man, I hadn't seen before in a video game. It was first-person shooter, so it means that you're seeing the world from your view, right? And you land on a planet, and you're this guy named Master Chief, and you're the persona. And as you're walking through this world, the non-player, whatever they call those characters, what they call those characters that that interact with you but not part of the game, non-player NPCs, maybe non-player characters.
Non-player character, yeah. There you go.
Yeah, right. Something. The gamers know this cult, right? Anyway, so these non-player characters was interacting with me, but to help me now figure out how to use the joystick. They're like, hello, Master Chief. I'm like, hey, is it try squatting down? Okay, how do you squat down? Then next thing on screen, it'll give you how to do it. And that's when I realized, oh my goodness, we're outgunned. If this video game in my basement by myself is teaching me how to use this complex 32 different controller while navigating a three-dimensional world that has these beautiful suns, mountains, landscape, water. You're walking through water, you can hear it, right? The plasma rifle you're carrying has a shadow on the ground, and there's no sun in this world, right? It's like, wait, what is this? And then I realized that game is made up of all ones and zeros. A human did that. And that EHR is made up of ones and zeros. A human did that. Well, what's the next logical thought on that one, Craig? It's like, somebody's not talking, right? I mean, I could literally take lives, virtual lives of people all night in this video game or aliens easily. And it takes me 40 clicks plus 15 mouse miles, I don't know, to order an IV drip the next day in the hospital. That's crazy talk.
So why do you think there was, and probably still is, a big disconnect between what you had at home in your basement and the technology that you were using in the hospital?
And you probably could help me out with this one as well. My thoughts is that, and I looked at it a little bit. I think just the financial models right now, the gaming industry almost fits in entertainment, right? And I think we've misaligned and misprioritized things a bit. And when you're designing for a single person or persona, you can be very niche and focused, unlike the electronic health records, which it's like a big Swiss knife, army knife that everyone uses a little bit differently. And so I think from a company vendor shipping out a product and not allowing, if a user adjusted it, personal settings on those video games, it's just for me. But when you start touching a setting like Epic, well, you're not only affecting you may affect a group of you. And so those are decisions that need to be made now, right? So now you're getting into governance. Like, what changes? Do we move this? In Halo, I mean, when they were testing Halo before they shipped that, it's like how they had like 20 all age people lined up, and they had girls, boys, they had grown men, women, they had all sorts of folks lined up, and they put these fovea cameras on all their eyes, and they tracked everywhere they're going around these fantastical worlds, right? And at the end of it all, what they knew was like they were going for about 13 to 16 hours of gameplay, I think. Because at that time, they knew if you get 13 to 16 hours of gameplay, that's your sweet spot. The game works, right? And so if you go below that, it's too easy. They get bored of it. Above that's too hard. They'll abandon it, right? And so they continue these tweaks where they would look for see where the hot spots on valleys and riverbeds, wherever the aliens were pretty aggressive. They saw these hot spots where the players weren't succeeding, right? And they looked at it and they analyzed, we didn't make the weapons or all the things that we planted in the bushes. We didn't make them big enough. so the players could see it. So when they increased the size of it, or they gave them extra weapons in that area, now they saw that they got out of that area, right? It was just the study of just a video game, Craig. I mean, this is not saving lives. This is a video game. All this work went into a video game. And at the time, I couldn't get my company to even pay for a piece of software called Camtasia that I could use to make a training video for docs. It's like, and so I think that was a disconnect, you know?
Well, let's talk about the video game for just another second. So gamification, the idea of taking something that's work or, not that much fun that you don't do on your spare time and turn it into a game. Can we gamify the EHR a little bit more, or are we doing that at our own risk?
I like that concept. I think that there are some things that we can continue to steal from every vertical, not just the gaming industry. Definitely gamification works. We know psychologically, you got to figure out what is a dopamine hit? Where can we find some dopamine hits, right, in this EHR? But in order to know that, we have to interview. We have to understand the users, right? What do they care about, And also sometimes you can't even you can't ask them questions sometimes because they just don't know. And also muscle memory is so strong in there where you say, so how do you order, say Augmentin today? How many clicks does it take to order Augmentin today? Or docs complaining about, well, I can't find the echo anytime I order it, so I just have my nurse do it, whatever. Whenever you do that, what we find is that physicians as a whole, typically, when we get frustrated, we get quiet. We may complain once or twice, but if we get no response once or twice, that's done, And so the silence has been mistaken for a good thing because when, you and me, we go into companies, we evaluate them as a consultant, as a strategist. When you're talking to folks, sometimes, well, the doc's not really complaining about that. Okay, I don't complain about Outlook, but
I do. For the record, I do complain about Outlook, but yeah, go on.
Exactly, right? Yeah, but I think those are not silence is not golden, unlike in the movies, right? Sorry. Silence, you better take a peek under there. And so what we've been doing lately, though, we're leveraging data to help get the volume of the docs, right? You can ask folks things, just like medicine, right? And I approached consulting with companies like the SOAP note, subjective, get the voice of the customer. What are the docs saying? What are the complaints, right? Get that, subjective, right? And then you say, okay, objective. Well, what's the data? Do you have any data? Do you have any objective data from Epic, the software, or they using it, things like that? Look at the data, right? And you can even augment that with a nice survey to fill in those gaps between what the docs say in the survey, right? What the data says. And then after that, you come up with, almost like an exam. What's the exam? Well, you go around, look at the place, people processing tech. And then after that, you come up with a nice assessment and here's a plan. So that's kind of the way I approach these type of things. And what I focus on most, what we should focus on most now, I feel, is UX and UI. That's just a big word for user experience and user interface. A lot of docs and people that use these tools don't realize you can easily move that button here or move this here or remove the clutter. I call it Marie Kondo. You can Marie Kondo the hell out of this thing if you want to take a minute to do it. It can really make your workspace minimalist. And so your attention goes where it needs to go at any moment of the day. And that your most common task or the things that you do daily the most is streamlined, automated, or whatever. So I don't know, that was a long-winded answer to your question.
So that brings up an interesting point. How much control do we give to the user, and how much control do we keep on the administrative side? If I let you change all kinds of things, then it's going to be very difficult to support. Right when you call the help desk, I don't know where that button is because you changed it, and the person next to you can't necessarily help you anymore. If you're like, oh wait, where's that thing? Oh, it's the button on the left. Wait, I don't have a button on the left because I changed it 2 years ago and I don't even remember how to do that. So where is that sweet spot of kind of standardizing on one hand, but also allowing the individual user to change the things to make it work specifically for them?
Yeah. Well, that's a solid. I don't think I'm going to give you a good answer for it, but there's a couple of examples I think that folks will resonate with, we need to think through. And just sometimes when I had a hiccup or when I really just jacked it up back in the day, giving the docs way too much control and causing confusion and everything you just said versus being more paternalistic and taking everything away, right? It's there's somewhere in the middle. And I find that it's usually organization type specific. For example, on Secure, we were 15 hospitals, 5 states, right? Okay. And within a hospital, there's a lot of variation. Okay. Now, within the next hospital 2 miles away, there's a lot of variation. Okay. Now, in the next state in this hospital, there's a lot of variation. So the question is, does the tools that we provide for the nurses at hospital A work for B, right, in the same region? And then let's extrapolate out to a new state like New York, right, where the nurses have very limited scope of work because they can only do like 2 orders. I don't know if this is true, but it felt that way when I was there. Okay. So please check the regs. In New York, check yourself. And California, you too. Anyway, it's very limited. Okay. And I'm like, what is going on? But we had to understand that so we can now create the software effectively so that the nurse work within the scope of practice. Whereas in Texas or some of the other places I've consulted, Guthrie, the nurses have a little bit more range. They can do more. So you give them more permissions in the EHR. These are some really interesting topics. These are niche areas that your viewers may or may not know about, but everything we do in that EHR has like a switch that should they be able to do this or that, or yes or no, almost as an outlook. Like, should we allow every user to reply all or not? That's a really big decision, right? And how would we know that? And so that's the things that we've been dealing with for over 20 years with this EHR. Who should be able to do what, when? And so managing all the complexities of that with of the technical complexities with real life, where we all know this, the EHR is made up of ones and zeros. The human body, I mean, that's like at least 256 shades of gray, right? I mean, it's not black and white at all. And so what we've done is try to get these very rigid IT systems, ones and zeros, to accommodate a very complicated model of human care, caring for humans that we didn't, and we still are practicing that. With the practice of medicine, kind of what they call it. And so I think that's really what we're running into. And now you got to mix the complexities of healthcare in the U.S. And I'm going to say that again, healthcare in the U.S. is very complicated because of the payers. Insurance wants certain things from the EHR, the doctor's workflows, that now we have to think about that when designing, where we never had to think about that with paper and a pen, right? Paper and a pen, you walk in the room, you give them what you give them, there you go, and all the magic happened in the background. And all that background now has been pushed to the front. And that's what we're seeing across the U.S. physician burnout, due to administrative tasks being pushed to them, and also folks not working to the highest of the licensure. I mean, I can't tell you how many times I've been in an organization where they have an RN. We did some data reports. We had an RN that was consistently taking vitals in the clinic, and they had like at least 2 MAs in that clinic. Okay, that's all I'll say about that statement, okay? An RN that is taking vital signs, but you have MAs there that could do that. And so the question is there higher levels of work that the RN could do based on their licensure, right? And maybe, is that a technical problem? No, it's not a technical problem. That's an operational problem, right? And so I think what Epic and these softwares have done, it has forced hospitals to grow up, mature, standardize things really fast and to sustain it. And I think hospital systems are now realizing, like, whoa, this software is kind of cool, but at the same time, it takes a lot of work.
How do you find that sweet spot between, I'll give you the stereotypical IT answer of no, every nurse has the exact same screen because nurses do the same things, and every doctor has the exact same screen because they do the same things. That maybe is as far shifted to the IT version as possible. Now to the doctor and clinician and nurse version is, hey, I'm a cardiologist, but I practice differently than the cardiologist next to me. And so don't even tell me. I don't even know what a gastroenterologist does. That's a different planet. They're aliens to me. And so I need to have exactly what I want, the way I want to see it for every screen. And clearly both parties can't get what they want. So there's going to be somewhere in between. I think it started off 20 years ago is much more on the IT side, right? Like, hey, either A, our software doesn't have the opportunity for you to personalize, or B, if it does, we're not going to give it to you because we think you're going to mess things up. And when you call us and ask us questions, we're not really going to know how to answer them because we can't see exactly all the changes that you've made. Right. And I think we've moved further to the right with giving users more opportunities to kind of standardize. And yet I'm still frustrated and maybe you are as well, still seeing physicians, mostly I'm going to pick on physicians, not other clinical folks, who complain for valid reason that there's too many clicks or this is really not intuitive. And then when we offer to kind of help them or, hey, there's ways you can personalize these screens to make them look better. They say they don't have time.
Yeah. So I call that, there's a phenomenon I think I'm going to label called the rental car phenomenon, right? You ever go on vacation, you get a nice rental, right? You're like doing it. You got the Sirius XM radio. You got the CarPlay built in where your old 2016 Ford, mine, doesn't quite have that. And so you get used to a different level of tech and experience, right? And then when you come back, you're like, oh, you're kind of like, blah, your car is not like it used to be, or your TV is not as better as the hotel TV, whatever, right? Well, the same thing happens with docs, but it happens every day with their iPhone, with Amazon, with things that they use that are intuitive, and then they come back to the EHR like, right? They don't know they're feeling that, but that dopamine hit happens, okay? Because that's what we do. Like they're experiencing really good tech outside of healthcare daily, outside of their job, whether it's the iPhones, the cool apps, the Chrome extensions, and all the cool things we do, right? And to be efficient. But then within our practice, within healthcare, it's like, nope, we can't do that. Nope, we can't do that. So right now, I feel like the patients have so much tech, and the docs are kind of, we're still playing defensive, man. We're playing defense as best we can because our health systems are slow as heck to get us the right tech. Even with the AI, great example is AI stuff, right? This AI should be all over healthcare system right now, and it's happening faster than we think. When I say AI, narrow AI, for example, the Note, DAX, those things like that. Boy, that got mature really fast. And that is probably going to be the number one savior, I'll say, of physicians' time and brains in the next year. That's my prediction on that one. But because of if we can get it rolled out to those guys fast enough, to the folks in the front lines fast enough, right? And that means going through legal, risk, compliance. I know all of them in these health systems. I work with 4 large health systems, and I tell you, getting through those for legal, risk, compliance, and quality, those are some really hard barriers of getting things to the front line of the docs because everyone almost has to sign off on it somehow, And so I think once we get better at streamlining those processes, say, okay, this does this, and here's the negative effects of it. And if they're negative, then how do we mitigate that as a system? Focus on that, and then let's get it in. Amazon created one click, God knows how long ago, right? And I'm sure there were folks like, well, you can't do that, Amazon. One click? I mean, come on. What if all the what ifs, what abouts, right? It happens in the room. Well, sometimes you better make a decision, right? And then be ready to mitigate, okay? And I think those are sometimes, when you make a decision with incomplete information, that means you better have a game plan, right? To say, if this happens, we're going to do this. If this happens, we'll do this. And I find that healthcare, sometimes we don't make a decision until we have all the data and 100% accuracy shot, and that's just unrealistic in 2023.
That's an excellent point. So from a healthcare system or from a hospital administrative or from an IT leader standpoint, you're absolutely right. We can't, paralysis by analysis is the term, right? That we just can't make a decision until we have all the information. However, every single day, doctors and nurses and therapists are doing exactly that, right? In the emergency room, they never have all the information that they need. And in the middle of a surgery, you don't have all the information that you'd like to have, and you have to make a decision. And sometimes you go with your gut, and oftentimes it's the experience. But we're not able to kind of leverage that on a system-wide standpoint. And I get it, but it's still, it still stands that you're at some point you're going to need to make a decision and move forward. And no one knows exactly where that point is. When do I have enough information and experience to make a decision when I'm representing the entire system?
Solid. And you and I have been in those positions. You've been a CMIO where like, well, if I approve this is going to be turned on. It's going to affect 800 docs, right? Now, that was a gift and a curse that we've been given as CMIOs, right? Now, I take that. I remember when the times came, I think it was a issue when we had 36,000 diabetic patients. I created like 7 tools that we're going to push into Epic, and it was going to help all docs manage diabetes better, right? And I just remember like when it happened, it was like the next week, it was almost like, I was like, wow, you could see like folks are using the tools that I came up with, and you can almost see like, okay, hemoglobin A1Cs are going down over the next year, and they were directly linked to those tools. So what that told me was, wow, just like you can make bad things go viral, maybe you can make good things go viral. So that was my hook into this whole EHR game, to say, how can we do this for good? How can we make clickbait that's cool clickbait? That, you know what I'm saying? How do we do this for good? So that's kind of the way I like to approach things now. I steal from other industries, whether it's banking, restaurant, whatever ideas I see, I say, how can we put it here and make it cool? So I think that segues away. I think I read in your book, you said in your book, Craig, you said this, and I forget the page, you said, we need more CIOs, we need more chief imitation officers. Yeah, I thought that was really cool. Yeah, I love that.
Let me be clear. I don't think that's certainly not my line. But the idea is that there's so much good out there, and why does everyone think that they need to figure this stuff out on their own? Just find what others have done, and if that works for you without modification, then just use it. That's what we do in healthcare, right? That's why we publish a study to say, hey, I found this thing, and hopefully it works the same way for you and your patients as it did for me and for mine. Dr. Butler, you mentioned earlier in the podcast that you work for a company called KeyCare. You mentioned that the CEO and founder is Lyle Berkowitz. Longtime listeners of the pod will perhaps remember Dr. Berkowitz was actually the first person we interviewed for the podcast. So it's all going in a circle now. Tell us a little bit about KeyCare, and I'd love to focus a little bit on what you do with virtualists. First of all, what is a virtualist? And secondly, how do we help these people?
Yeah, so virtualist is a term, relatively new term to me, kind of like back when the term hospitalist came out. And I think maybe when the word sniffist, remember sniffist, SNF-ist is a person that handles
I think you're making up stuff now. Now you're just making up stuff.
I may have made that one up, but you get it. Virtualists are providers that typically spend like over 80, 90% of the time in a virtual setting as far as care for patients, not necessarily in real life, brick and mortar type. Okay. So this KeyCare platform is a startup maybe a year ago, been live a year ago in Epic. I get a call from Lyle maybe, and then summertime. Say, hey, Dave, you got a minute? I say, yeah, what's going on? I say, yeah, there's just some white noise we're hearing from some of the users of the software. And they just want you to take a peek at it and maybe also serve as interim CMIO for a while. I'm like, great, let's do it. And so while in there, just like I said before, how you go into a system, you look at things, you say, who's talking? Can I interview docs and things like this? Well, virtuals are so busy, right? And they're also episodic, and they have multiple other platforms that they're working on. So it was a bit tricky to try to get their attention like you would do in a traditional healthcare system, where you say, okay, what, the docs and the ortho hate this? Yep. All right, we're meeting with ortho because they have a meeting every Friday at so-and-so. So I'll go to that meeting, get input from the orthos, and we go from there. And you find the strong personalities and you figure out how we can negotiate, deal with this, yada, yada. You do that. Well, in these kind of environments, that's not so, because you have a lot of different docs hitting the platform, and they're going a lot, and they make their money. I mean, they get compensated with time. And so I'm going to ask them for an hour of their time to tell me about something in their software. Most of, that's just not you could try it, I tried it, but they weren't biting. So, and once again, there was a lot of white noise, not signal. And that's what happens. Whenever you get the white noise, it's docs that complain and move. And you're not quite sure if we could put how much validity to put on it, right? So when we run into those situations, then we have to go hard data. I'd say it's almost, I remember when we practiced in the neonatal ICU, right? Okay, those babies were so small, right? You couldn't really examine them. They're under saran wrap and all this protection and intubated and things like that. But the data was coming out. You saw how they did overnight. You saw the labs, right? You saw the KUB, right? You saw the opto came by, look for retinopathy of prematurity. All these things. Well, we had to go data. So that's basically our approach here. We went hard data. We pulled the PEP signal data, which is like Epic's ability to track phobias in a way, right? Time back to Microsoft. So let's get data and see where are the docs getting bogged down? What valleys and crevices are they getting bogged down in, so that we can then see, oh, there's something we could do on this side that'll decrease that friction. And so that's what we did. We spent like maybe a whole month just combing through data, the notes they used, the navigators they were using, the reason for visits they were doing, what was the encounter diagnosis, what were the meds they were giving. And then what we did say, okay, now we have hard data on what they've been doing for a year. Now let's look at the current state. Well, actually look at the current state first. The current state was there was a lot of docs that were ordering medication. They would then have to add like 10 milligrams or something like amlodipine. Okay, amlodipine, 10 milligrams is almost what you just start off with, whatever. So why should they have to pick that? Just find those things that are common to save a click. And this is what I call the Lord's work, because it's really detailed. And if done right, no one will notice. That's what sucks about the work, because you don't get the kudos, right? You don't get, oh, Dr. P, thanks for making this better. No, if it's done right, it just works. Almost like when Apple iPhone updates and something just cool pops out. Oh, that's cool. You don't call Apple and say thanks. You should have done it before. So it's kind of a thankless job when you approach things like that, but that's what we've been doing in the past. And so honestly, tomorrow, what's today? Tomorrow we have a whole pack going in the KeyCare that's going to help alleviate a lot of some of the white noise, and we're going to be measured before and after to see the benefits and things like that. And so the goal is, if we make this platform right, we want all docs that are virtualists to be coming on this and be like, hey, bro, forget those other ones. KeyCare platform is easy. We get on, click, 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 we're done. Get on, click, 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 we're done, and it's epic. That's what I'm going for when I design things. I want it to crush. I want docs to choose KeyCare because of the platform, because they know they can get in and get out. What studies have shown is that nurses would pick, a graduating nurse will choose a healthcare system based on the EHR. Like, that's crazy, but also it's a great market differentiator. And if in KeyCare, where our platform is the product, part of it, we also get a medical group. So kind of cool.
Yeah, it's funny what you said about Apple products and their design and your work as essentially an informaticist who helps design things to make them work. Not only do you not get kudos, often you get yelled at, right? Why did you change this? I hate this. I liked it before. And this is horrible, and I'm never going to be able to continue to practice medicine. And then you go back 2 weeks later, and you're like, hey, how about that change that you said was horrible and that you could never use it? And most of us will be like, yeah, I don't remember what was I complaining about. I know I've certainly done that on my phone. There's an app, it updates in the middle of the night. It's horrible. I hate it. I can't figure it out. And then 2 weeks later, if you sent me an email like, hey, we're going to put it back to the way it was, I'd be like, I don't even know what that is. Right. So
that's it.
We humans don't like change, even if the change is better for us. And it takes some time to kind of get over that.
That's it. I don't know. This is one of those things you can cut on the podcast later, but I think as a pediatrician, really, and this is one of those, as a pediatrician, there's certain patient types, especially those that we deal with, that personality types even, or as an adult, for certain personality types that change, type A, we know like this is the medicine for you, or this is a procedure you need, but you're looking in their eyes, you almost feel like they know it too, but they just not going to get themselves to do it, And so I think that's all. Change is hard, for everyone, especially when you have changed before for IT, because they said change and you do, and then you get burned. Okay, you're not going to be willing to change again unless you got some guarantees. And so I tell a lot, when I advise third-party startups, this is one of the first thing I say, whatever you do, just remember you're going in with a tool that's for docs, but these docs have a lot of antibodies right now to bad technology. Okay, so if they're not, you better really come with it, and you better stick the landing, as they say, the mixed metaphors, right? If your software had better stick the landing the first time, and you just have to do it, And so I have to kind of make sure they understand, like, docs are not just going to be, oh, this is awesome, let me add that to my workflow. That's not how it works. If it solves a need and it's seamless and frictionless, they'll take to it like a fish to a hook, right? But if it's not, don't get upset. They're like, well, I don't know why the docs are. Docs just need to do this. No. We're 2023. We're 2023. No longer is it the doc's fault. It's the software's fault now. Sorry, we're done with docs, okay? So, Halo, I talked about Halo. You design software the right way, it's easy. You do it. You put it, that's how our brains work. And, Netflix, when we're looking at Netflix, look at anything we design, anything in the world, whether it's Amazon, Netflix, whether it's Uber, Lyft, any of these apps, the United app, use those apps or other like the shopping apps, things like that. Those are examples of how it should be. And that what docs are getting used to over here, where we order things on Amazon, right, Craig? Right? We order things. There's order sets on Amazon.
I've never ordered anything on Amazon.
Absolutely, me either, right? But I order medications on the EHR. My point being, there's a basket. There's a shopping basket concept. You get this, you put it in a basket, things like that. There are things that we should be incorporating that are industry standard. I remember back in the day, I would always coach Epic's developers. It's like, look, they want to go all creative sometimes. Like, stop. Make it like Microsoft already made it, because they've already got our brains right here. So piggyback on that. Or things like that. Or like use someone. There's a term, skeuomorphism. I think that's like when you
make something look like the real world. Yeah.
Yeah, I think Apple Notes tried to do that with the yellow and the lines, or OneNote will do that sometimes. They're trying to make it look like a legal pad when you don't really need the lines of a legal pad anymore, right? But it helps humans get over the hump sometimes. So I think using some more of those would probably be pretty cool. I don't know all the words, all this. I just like to throw out stuff. I'm sounding smart.
Yeah, same. All right. Well, Dr. Butler, as we get near the end of our episode, we always like to ask our guests if they have some examples of design that they think or products that they think are designed so well that they bring them joy. And so are there some things that are in your life that you think are designed so well that they always make you smile when you use them?
Bring me joy. Make me smile. That's a lot, Craig. I got some funny friends like you, so I'm not going to, I don't want to compare a product to somebody and make me laugh like you. So I'll rephrase it. I'll say products when I use it, I don't think about it, right?
Fair enough.
I don't think, because if I have to think about it, then it's not enjoyable, right? and so I think it's a whole book called Don't Make Me Think. It's a guy named Steve Krug, Don't Make Me Think. He wrote this book and he's got a version. I give it to all my analysts most time when I work with them, because basically it's about software design. Just, like this color should always mean this. Okay. Top left should always be where eyes go. Things like that, just design principles. And so I think about when I think of software and that book, Design of Everyday Things. You like that one as well, right? I think you mentioned that a couple of times in your podcast. So I think the thing that brings me joy now I think about it, it's like I was in the closet, my tech closet is ridiculous. Cables everywhere, right? And I'm always going in there. I don't feel like organizing because you got this end that look USB-A, this end is Lightning, this end USB-A, this end is something else. Yeah, like the ends don't match. And so when I was in the closet the other night, I realized like when I saw a HDMI cable, I was just looking for HDMI cable. I got a new TV last week, right? So I was just looking for HDMI cable. And as soon as I saw the HDMI cable end, I knew the other end was the same. I got like, perfect. I love this cable. I love cables like that. There's no decision to be made, Craig. This end of HDMI looks like this end. And that's it. And I knew upside, and I like USB 50-50. You're doing a chance? No. And so I think that's one example.
It's interoperable, actually. So I mean, that it's actually funny that you say that, right? It's interoperable, and you can't put it in the wrong way because there's some transparency about how it works, as opposed to your traditional USB-A cable where it's 50-50. Good luck.
Yeah, you can literally break that thing thinking you got it in the right way, trying to push it in. I don't know, but I'm glad. Yeah. So that's one. Also, the other day I was in the grocery store. It's called Raley's out here. I think the East Coast has Wegmans, down south they have Randall's, and Pacific Northwest they got Publix. I don't know, somewhere. It's a grocery store chain, basically. There's a software that allows you to, when you go in, they want your phone number to give you discounts, get you in the matrix. That's fine. I give them my phone number. I'm in their matrix. That's fine. Because the benefits finally outweigh the risk. Okay. So now, because when I open the app, it knows all the things I bought before, right? So I can easily add it. On this when of course I use Instacart and all that other stuff, but I don't. I like to walk the grocery store, get a little exercise, right? So the app is really slick because what it does, there's a sub feature. Now they need to make it more prominent, but it says by aisle, where aisle 1, aisle 2, aisle 3. So it breaks up the list into the aisles so that I can be more efficient just going through the aisles that I need to go through. So I thought that was super smart because it has to be tied back into the supply chain, right? Like what's coming in. And so just organizing it for users, pretty slick. And I think I saw a little Instacart teenager running through using the same app. And so I don't know. I thought that was pretty slick design, and it makes sense. And it serves both sides. It's not just one side of the store, or it's a win-win. So
yeah. Well, and I like your definition of good design is design that fades into the background. I'm not even thinking about it. So it doesn't particularly bring me any kind of emotion. It just works.
Does this work? This works.
Well, speaking of just working, thank you, Dr. David Butler, for joining us today. Really appreciated the conversation. Had a good time, and look forward to seeing what you're going to do in your young career. What amazing things you'll do in the decades you have.
Well, hope you ask me to come back, and I'll update you in maybe 3 months. I think 3 or 4 months will be really cool follow up to just say, well, did you say what's going to happen? Did it happen? And that way I can eat crow, or you can sing my praises. I don't know.
Fair enough. We'll have to see what happens. All right. Yep. Thanks again. Thanks for tuning in. We hope you enjoyed today's episode. For more information about David, visit calyxpartners.com. Check back for more episodes of Designing for Health wherever you listen to podcasts or on nordicglobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.